Good afternoon, and thank you for joining us for our Healthcare Check-in webinar discussing the latest developments in health and welfare plans. My name is Christine, and I will be your moderator today. ERISA attorney Larry Grugin is our presenter. If you missed something, don't worry, we'll be emailing you the recording with the slides after the webinar concludes. I'll be keeping the webinar muted to avoid any background noise. And we'll pause at the end for any questions. Simply type your question in the box and I'll read it aloud for you. If we don't get to your question today, we'll be sure to email you a response. To kick off today's webinar, we will begin with a quick poll question. All right. As we approach the 2019 plan year, which of the following benefits administration strategies are most important to you? Please select one. Improve effectiveness of self-service platforms, help employees make better benefits decisions, increase employee financial benefits education, or lastly, tailor benefits to specific employee segments. All right, we'll wait a few more minutes, probably a minute or so, and then I'll go ahead and share everyone's results. It's anonymous, by the way. All right. Okay, I'm going to go ahead and read everyone's responses. Looks like 34% chose help employees make better benefits decisions, 29% improve effectiveness of self-service plans, and here we go. And then 26% of you increase employee financial benefits education, and then 11% tailor benefits to specific employee segments. Thank you all for participating in our poll, and I will go ahead and let Larry take it from here. Thanks so much.
Thank you very much, Christine. I appreciate it.
Yeah, of course.
In today's seminar, I will, what I think, cover what's happened over the last 6 months that are important. Here's a listing, that's next slide, of everything I'll be covering today. I'll be covering IRS updates of guidance and employer-sponsored shared responsibility in 2018 amounts that were released earlier in the year, proposed regulations to expand availability of short-term limited duration plans. Just last week, they released the final regulations. I'll be talking about that. IRS revises some 2018 benefit limits due to tax cuts. That was extremely embarrassing to the service. The IRS clarifies male sterilization and contraceptives are not preventive care. You have to check your plans because it could prevent HSA eligibility. Agencies issue more mental health parity guidance. It's extremely important because I've been running into this issue more than just several times where plans are not in compliance with the mental health parity. There's some important things in there that I want to highlight that you should look at your plans because some plans, not all, but some plans are in violation. The IRS announces 2019 HSA contribution limits. The IRS announces ACA index adjustments for affordability and tax credits for 2019. I'll be talking about employer tax credit for paid medical leave. That's a big issue right now in many parts of the country. And lastly, I'll be talking about the DOL releases final rules on association health plans. Now, this is a short introduction. It goes on for about 15 slides. On Thursday, I'm having a full-blown seminar on this. If you would like to attend at the tail end of the presentation, and I'll stop on this, is my email address. Email me. It's a free seminar. I'll send you a copy of the invite, then you can register if you want more about this. But right now, in this seminar, this is a short introduction. So let's look at this. So the IRS updates guidance on employer shared responsibility. This is for 2018. This was earlier in the year. And remember, there are certain aspects of the ACA that the limits keep on going up. For 2018, the penalty limits went up to $23.20 for the A penalty and $34.80 for the B penalty. And then again, this will be adjusted year by year by year. Also, the affordability standard went down to 9.56%, and all the transition relief that applied for 2016 and 17 goes away, and there's no more transition relief. That's one thing they indicated. So this is something that you've been living with for a few months. Let's look at next proposed regs, and I indicated final regs were just released on August 1st. This is after I prepared the slides, and I'll tell you what the proposed regs say and what the final regs say, so you can understand exactly what are short-term limited duration insurance plans. So the DOL, and this is a joint effort with the DOL, HHS, and IRS, jointly issued proposed regulations that would expand the availability of short-term limited duration health insurance. And basically what this says is the fact that the period, it has to be, for any coverage under this program, has to be less than 12 months. Now this is important because under ACA, it was originally less than 3 months, so they've expanded that. And then as this slide says, this extension would restore the previous applicable maximum coverage period, reversing on October 2016 final regulations that reduced the maximum period of duration to less than 3 months. So this, again, moves it to 12 months. Now with the final regulations, what they say, which were, it's going to be effective sometime in October, is that they kept it less than 12 months, but the absolute duration of these plans cannot exceed 36 months. So truly, these are short-term plans that people can now. What's interesting about these plans, they're cheaper than regular plans. They're not subject to the ACA guidance in regard to coverage. Insurance companies can impose pre-existing conditions on these plans, and they have limited coverage. So they're not intended to be long duration plans. They're considered to be a stopgap until somebody can find better coverage. What's also very interesting is this next slide that indicates required notice must appear in enrollment material for short-term limited duration insurance plans that have been revised. The final regulations have been revised again. There's two different versions of this. Both versions of the notice are intended to warn consumers that short-term limited duration policies are not required to comply with certain federal health insurance mandates, principally that are contained in ACA. What I'm concerned about these plans is younger, healthier individuals with no pre-existing conditions will buy these plans because they're cheaper, and this will accelerate, and maybe damage the individual market for health coverage on the exchanges. So again, if anybody you know wants to enroll in one of these plans, remember that many of the healthcare reform requirements, essential health benefits, don't apply to these plans. They're cheap plans, they're temporary plans, and this is something that, as a stopgap, the administration is offering. So please be warned. The IRS adjusts some benefit limits for 2018. Earlier this year, I think it was around February or March, the IRS released a notice, 2018-10, that said they're going to modify and certain limits for 2018. And what they did was they reduced the amount of the HSA contribution from $6,900 to $6,850. They also reduced the amount of the adoption assistance from $13,840 to $13,810, and the employee health insurance expense for small employers were also reduced from $2,670 to $2,660. What the IRS didn't realize was that many people put in this full limit for HSA contributions at the beginning of the year. So basically what happened is many people had to take $50 out of their plan because of the fact it would be deemed to be an excess contribution. It was very embarrassing. And what's interesting is the fact that this was part of a new tax law that came out. And they changed the way, and it took the IRS several months to figure it out and say, oops, even though we've announced the limits, this is before the previous law was passed in Revenue Procedure 2017-58, they then reduced the limit on HSA contributions. Well, lo and behold, a few months later, in Revenue Procedure 2018-27, the Treasury and the IRS said, for the best interest of sound and efficient tax administration, they were going to restore the limit from $2,850 to 69, from $6,850 up to $6,900. So everybody that took the money out when the previous guidance came out had to go back and take it and put it back in again. So an individual who receives a distribution from the HSA of a excess contribution based on the $6,850 deduction limit published in the previous revenue procedure may repay the distribution and treat it as it never happened. So this was, again, very embarrassing to the Internal Revenue Service. Next, the Internal Revenue Service announced in Notice 2018-12 that the IRS clarified that health plans covering male sterilization and male contraceptives without deductible, basically what they indicated, many state laws require this as part of preventive care, but it doesn't match the definition of preventive care in regard to federal law. So if a state law requires that they be covered under preventive care, the federal law doesn't. So it could potentially make an individual ineligible for an HSA contributions. So as this says, these benefits are not preventive care under the Social Security Act or IRS or Treasury guidance, nor are they preventive services that must be provided without cost sharing under healthcare reform. So the plans that provide these benefits before a high deductible minimum deductible is satisfied are not high deductible plans. Even if the benefits are required under state law, an individual who is covered under such plan is not eligible to make or receive HSA contributions. So they clarified that. Now, understandably, many people are upset with this, and what the notice indicated, as this is the IRS provided transitional relief before 2020, so this can continue for the rest of 2018 and 19, but starting in 2020, coverages have to be changed to eliminate this particular benefit So kicks in before, after the deductible to make sure that people are eligible for HSA contributions. Christine, if anybody asks any questions, please interrupt me. I don't want to wait till the very end. So
sure.
if you
got it. Oh, no questions yet.
Okay, no problem.
Thank you.
So the CMS extends transitional leave over the last 4 or 5 years. These are considered grandmothered plans. And what that means is that as transitional relief, the CMS allowed certain insurance policies, both individual and group, to continue on a year-by-year basis, even though they don't contain all the ACA requirements that were effective in 2014. On a year-by-year basis, they keep on extending it. So on April 9, 2018, the Centers of Medicare and Medicaid released a bulletin which extends transitional policy to policy years beginning on or before October 1st, 2019, provided the policies end by December 31st, 2019. This has been going on for 3 or 4 years. So as opposed to grandfather plans, these are called grandmother plans. And these policies can continue. Policies subject to transitional relief are not considered to be out of compliance following the provisions of the public health center. And this is the whole list of various requirements that these policies, and both on the individual and group side, don't have to comply. And as the previous slide indicated, this can continue until December 31st, 2019. Now, what's interesting about this is the fact that it depends on the state that your policy is written on, because some states make it required. Other states say, and I looked at Indiana, they said, well, it's up to the insurance company whether they want to continue these policies for another year. So you have to check with your broker and your insurer to see if you do have a grandmother plan, do you have another year to continue that coverage?
Hey, Larry, we do have one question here. It's asking, can you give an example of a transitional policy?
Well, here, these are the various requirements, and these were ACA requirements that kicked in 2014. And these are the sections of the Affordable Care Act that apply. So, for example, let's take one extremely good example. In the middle of the pack there is a relating to prohibition on pre-existing conditions. That transitional policy can continue to have pre-existing condition exclusions. This is a special exception for these policies. So all these conditions and requirements that apply under ACA, if you have a grandmothered plan, those provisions don't apply to those grandmother plans. So again, that is a fine example of something that it can still exist. You didn't think it would still be around, but it is. And that one provision is extremely important, and under certain conditions can continue. Now, as it says here, they're relating to the prohibition of pre-existing conditions, exclusions, and another based on health status with respect to adults, except with respect to group coverage. So I think it would apply to individual coverage, not to group coverage. But again, all these other requirements would apply to group plans, and they don't. And again, generally, these are ACA requirements that kicked in 2014.
Okay, got it. Thank you so much.
Okay. Now, a few months ago, the agencies proposed additional frequently asked questions of mental health parity. And I run into this every so often where either self-funded plans or other plans are not aware of the fact of violations of the mental health parity. So as this says, the guidance was prompted by the 21st Century Cures Act, which was passed in 2016, which required that agencies to improve mental health parity compliance by issuing additional guidance and soliciting feedback on a variety of mental health parity topics, including how to improve required disclosures. Now, what these questions did, and I highlighted some important areas. So several frequently asked questions address the application of experimental and investigative and treatment exclusions of mental health and substance abuse areas. Now, what's important here, and overarching theme here, is the fact if you're applying certain limits to health benefits, those same limits have to apply to mental health benefits. So it is extremely important. And so one question focuses on the applied behavior analysis therapy for autism disorder, explains that the medical management standard limiting or excluding benefits based on whether a treatment is experimental or investigative is non-qualificative treatment limitation, which means it's not permitted. They frequently ask question that a plan violates the parity rules if operationally applies such limitation or exclusions more stringently to mental health benefits or by excluding all claims for ABA therapy. And circle that, because that I see that every so often in coverages where either on a self-insured basis or a small employer basis, that still applies. Another question examines unconditional exclusion of experimental and investigative mental health and substance abuse benefits based on medical management rating standard, which are not permitted. Next, one question explains that even though prescription drug dosage limitations on to treat opioid or use disclosure are medical management techniques that result in numerically expressed limitations, the techniques are nevertheless non-qualitative treatment limitations, which means they're prohibited. It concludes that a plan that follows dosage requirements and professional recognized treatment guidelines to set dosage limitations of prescription drugs to treat medical and surgical conditions must follow comparative treatment guidelines and apply them no more stringently in setting dosage limitations for prescription drugs to treat mental health and substance use disorder conditions, including opioid use disorder. So please check with your TPA or insurance company and make sure they understand the fact that these rules came out. They have to be very careful in, especially drugs to treat mental illness. Are they applying the same standards as they would under medical or surgical? Another question considers a plan's exclusion of prescription drugs for bipolar disorder and concludes that a general exclusion of all benefits, including prescription drugs for a particular condition or disorder, is not a treatment limitation for purposes of parity rules. So in that situation, it cannot be done. Also very important, and check with your provider, is the fact that two questions address out-of-date and otherwise inadequate mental health provider directories. One question explains the DOI regulations require SPDs to provide a general description of the plan's provider network, including a list of providers that are up-to-date, accurate, and complete. And again, in this area, many employers don't provide a complete SPD. They may provide a summary that doesn't include this information. So you have to be sure that what you provide to your employees provide this information. Another question is a reminder that a hyperlink or other web-based for provider directly must be used in enrollment and plan summary material so long as the DOL's electronic disclosure safe harbor requirements are met, which means if you have employees that don't have a computer at home, then they must be given a paper copy. Those disclosure safe harbors are very clear on that. Also, please, agencies also have revised the draft model disclosure form that participants, enrollees, and their authorized representative must use to request information from their plan or insurer about the plan's non-qualitative treatment limitations. Make sure your TPA, your insurer, are using the right form. Plans and insurers are required to disclose the criteria for medically necessary determinations with respect to mental health and substance use disorder benefits to any current or potential participant, beneficiary, contracting provider on request, and must make available the reason for any denial or reimbursement or payment for services to the participant or beneficiary. And remember, all disclosure forms, as it says in the last bullet there, have been changed as a result of these questions. Let's move on to the next one, HSA contribution. And this was released in May of this year. These are limits for the coverage limits for high deductible plans. Here are the annual HSA contribution limits. For individual, it's gone up from $3,450 to $3,500. For family, it's gone up from $6,900 to $7,000. And the catch-up never changes. It's always $1,000. And the out-of-pocket limits for a high deductible plan for individual goes from $6,650 to $6,750, and for family it goes from $13,300 to $13,500. Now, it's extremely important that you check with your broker to see if your plan qualifies, because many times people set it and forget it and don't change their coverages, and all of a sudden halfway through the year they realize, oops, we didn't make the adequate changes to make sure they're in compliance. So make sure that's the case. The annual deductible limit, and this is something that's very many times isn't checked. Now, the relief is for 18 and 19, those deductible limits are the same. So no changes have to be made in this situation. Also, the IRS announced ACA indexing adjustments for affordability and premium tax credits. I just told you about 2018. 2019 have been announced, and what's been announced is the affordability limit. It goes from 9.56% for 2018 to 9.86% for 2019.
Hey Larry, can you hear me? It's Christine. I think we lost your sound.
Christine, can you hear me?
Yeah, we can hear you now. Thank you so
Okay.
much. Yep, we're good.
I got a notice, so good. Okay, thank you.
Yep, no
All right.
problem. Thank you.
Okay, next, let's look at the employer tax credit. This is something that there's been no regulations and no official guidance. Only thing that's been released so far is frequently asked questions. So this was part of the tax bill that came out in December of 2017. This tax credit is provided under Code Section 45S and gives a tax credit of the 25% of the wages paid to employees on a paid family and medical leave. Now, remember that family and medical leave technically is applicable to any employer with 50 or more employees, but to qualify for the tax credit, you don't have to be 50 employees. It can be any employer that wants to give employees a paid family leave. So this is a special tax credit. You can get a tax credit of the 25% of what you paid your employees. So on April 9th, 2018, the IRS posted a set of frequently asked questions that explains, and this is part of the 2017 Tax Cuts and Jobs Act. So qualified employers must have a written policy for employees that provide at least 2 weeks of paid family medical leave annually for qualified employees and no less than 50% of normal wages. And that's what they're entitled to. Not every employee is entitled to this. The IRS notes that qualified employees must be employed for at least 1 year or more and does not receive compensation beyond the defined limits, and the limits for 2018 is $72,000. So your pay cannot exceed $72,000.
Hey Larry, we got a quick question here. It says, is the tax credit for paid family medical leave applicable to nonprofits?
Yes.
Okay, thank you.
So here, these are the reasons, and these mirror the reasons under the federal FMLA leave. So you can take it for the birth of a child, placement of a child with the employee for adoption or foster care, to care for the employee's spouse, child, or parent who has a serious health condition, your own serious health condition. Also, if somebody is going off on being called up and you have to do things in order to prepare for that, you can also take time, you get leave for that purpose, to care for a service member who is employee's spouse, child, or parent. And so they have to be given out for this reasons. If any wages are paid for leave outside of the above reasons, it doesn't qualify. So again, this applies to any employer, any size, that wants to give employees paid leave, and as a result, they get a tax credit. Now, the difference is in this situation, when you go on family and medical leave, you can use vacation, holiday pay, any type of sick time to have paid leave. Here, and as this slide indicates, one difference between the rules for tax credit and family and medical leave is if the employer provides paid vacation leave, personal leave, or medical or sick leave, other than paid specifically for one of the purposes above, the paid leave is not considered family and medical leave. So it's got to be a special program just dedicated to this in order to get the tax credit. That's what they're trying to say there. Moreover, any leave paid by a state or local government or required by state and local law will not be taken into account in determining the amount of the tax credit. So if you get reimbursed by the state or paid into a state program for paid leave, it doesn't apply. So once the qualified paid leave has been identified, qualified wages paid may include for each while on leave up to 12 weeks. The minimum is 12.5% is applied to qualified wages and increases 0.25% for each percentage paid to qualifying leave that exceeds 50%. And in that situation, and what I'm trying to say there, to get the maximum 25%, you have to pay the employee 100% of the wages. That's what that is trying to say. So wage amounts deducted on the employee's tax return must be reduced by the amount of determined as a credit, so you can't get both. One applies and then the second one applies, but you can't get both at the same time. In addition, wages included in other general business tax credits, credits for increasing research activities, must be excluded from determining the credit. So we're waiting for formal guidance in this. These were just frequently asked questions. And again, employers have expressed concerns on how to qualified wages paid by the employer's insurance provider in event of employee's disability, that may or may not apply, so I would wait before you do this until more final guidance is released. And employers will seek clarification as to whether to include disability benefits as wages in credit calculation or simply include premiums paid on relevant disability insurance policies. So again, I would wait to do this. Right now, we just have frequently asked questions, but this is something that I have not seen that much interest in it. All right, I'm going to give a brief presentation on final rules for association plans. As I indicated before, if you want more detail on this, I'm having a seminar at 1 o'clock on August 9th. It's going to be an hour to hour and a half. We're just going to discuss this area, but this is a good introduction to what these rules mean, and I will be talking about why they're important, what they say, what are the ramifications for employers, and what you have to look out for. So in June 19th, the Department of Labor released final regulations under the federal rules that offers new options for associations to sponsor health plans for their members. So what's important here, they changed the rules, so what you can do as an employer, if you wanted to, you could be a member of an association and they could sponsor a plan for you, a health plan, which means they could have an insured or self-insured plan, and the same benefit would be offered to all members of that association. Now, these new options allow more small business to create a large employer plan. And basically, if you're a small employer, you would escape the essential health benefit requirement under ACA because you'd be participating in a large employer plan. So this is generally effective for next year. I'll be talking about, I've talked to a lot of employers about this, associations. I've helped a couple of associations form and sponsor programs, so I can talk to you about that. But this is extremely important because you're joining the plan, you're joining a large plan. So why are these rules important? Under previous law, multiple employers are treated as a single employer under ERISA if they are members of a bona fide group or association. To qualify as a bona fide group or association, the employer members must have a commonality of interest, which the DOL has narrowly defined. To satisfy this requirement, the law required the members of the association be of the same geographic location or industry, thereby prohibiting national health plans in the same industry or plans with membership based on common geography, but no industry or business ties. The first associations that are interested in doing this are local chambers of commerce, are looking at this as offering a benefit program to their members. That's the first bodies that I've seen that are interested in doing this. So here, the new regulations revise prior DOL guidance regarding what constitutes commonality of interest and providing that the association members have commonality of interest if they are in the trade or business or located in the same state or metropolitan area, even if the metropolitan area includes more than one state. So you could have a situation where if you're a certain profession, a dentist, a doctor, a national association could sponsor a program, or you're in a business league or in a business organization, and your organization covers 3 or 4 states. This law, these regulations now allow you to join together and form one health plan. So as this say, under ACA, such a plan would be treated as a single large plan. So everybody would be in one insurance pool. Do the final regs apply to existing association plans that are formed on previous guidance? The answer is they kept the existing guidance, so you could go under the old guidance or the new guidance. So the final regulations expressly preserve existing association health plans that were formed to comply with previous guidance under the HIPAA rules. Some argue that because these plans are not designed their operations, it would be unfair if you change the rules halfway through the game. So the DOL agreed association health plans may continue to rely on the DOL's previous guidance, and they can continue the way they were.
Hey, Larry, we do have a quick question here that just came up. It says, so if they are a large plan, does that mean the small group would be subject to the employer shared rule?
Yeah, they would. Yes, many of this large employer, so they would be subject to the mandate. They would be subject to reporting. But again, the association would do some of this, and I'll be talking about what specifically would apply in a few minutes. So okay, don't worry, I'll be covering that.
Great.
Now, to be a valid association plan under the new regulations, what other requirements must be met besides commonality of interest? So the association must have a purpose other than sponsoring a program. That's what this slide says. So the sponsoring group association must have at least one substantial purpose unrelated to offering and providing the healthcare coverage or other employee benefits to members. But okay, the primary purpose can be offered health coverage. So the safe harbor under the final regulations deems a substantial business purpose to exist where the group or association would be a viable entity even with the absence of sponsoring an employee benefit program. It could be for general business purposes. It could be the advancement of some particular goal. They could have that. It could be education.
And we do have another quick question here.
Sure.
It says, can a state legally deny the offerings of an association plan?
Well, here's my concern. Here's my concern. And this is something I to 2 or 3 different departments of insurance in states. And here's what they haven't grappled with yet. Suppose you form an association in Indiana, and you have members in 3 or 4 states, and your contract is written in Indiana, but doesn't contain the mandates that are particular to Illinois, Indiana, or any other state. The question is, will the Department of Insurance allow you to function or force you to offer those mandates that are regulated? Because remember, the state laws still apply. These rules do not negate state law. And so far, the Department of Insurance have gotten that far yet, but I think that's an issue that you have to grapple with. Now, what's going to be, if you're in one state, it's going to be fairly easy. If you just want to cover the businesses in a particular location, and that location is in Wisconsin, and you meet Wisconsin requirements, no problem. But if you're in an association that are in 3 or 4 states and you want to offer the same coverage to all your members, I think in that situation, again, nothing formal has come out yet. Each state Department of Insurance may require you to jump through some hoops in order to be offered to employers in their state. So that's going to be extremely important.
Got it. Okay, thank you very much.
Now, the other issue, I think, what's very important, there has to be an organizational structure. So the group or association must have a formal organization structure with a governing body as well as bylaws or other similar minutiae of governance establishing the legal form in which the group or association operates. There was issues or problems in the 80s and 90s where associations were formed to offer insurance and they were just shells. So they're saying if you're going to form an association to offer coverage, It's got to be more than a shell. It's got to be a formal organization. I would think what you would want to do is form a 501c3 organization, not for profit, and do it that way. That's why I think associations that are currently in structure are going to be the ones that are going to probably take advantage of this first. Now, this one is an extremely important requirement. The functions and activities of the group or association must be controlled by its members, and the group or association's members that participate in the group must control the plan. All right, so control must be present both in form and substance, and it's a facts and circumstance-based test. Whether the members regularly nominate and elect directors, officers, trustees, or other similar persons that constitute a governing body, and whether the members have authority to remove directors, officers, trustees, and other similar persons, and whether participating members have the authority to approve or veto decisions or activities that relate to the formation, design, amendment, or termination of the plan. So does that mean that every time you want to change the plan, you have to have a vote of the members? Is that what that means? Now, what they're saying is the members don't have to do the day-to-day overseeing, but they must have ultimate major decision responsibilities. So the people that run the plan, the people that are covered under the plan, must control it. That's what that is trying to say. Eligibility. Eligibility include employees of the current employer and also spouse and dependents. Now, what they're guarding against here is the fact they don't want the general public to be eligible to participate to circumvent the insurance rules. They don't want associations coming into an area and say, okay, everybody that breathes in this area can be a member of our association. Come and join us. And that would circumvent the insurance rules. Also, can the association consider claims experience in determining whether the employer association for coverage or charge them more premium? And generally, I say depends because it all depends how the association is formed. If you're, for example, formed an association that covers certain technology companies, and those companies tend to be younger, more healthier, no problem. But generally in this situation is that if you're, for example, if you're forming, if you're a chamber of commerce in a particular location, and you're covering all businesses in your area, you cannot pick and choose who can join your association. But if you happen to form an association for a business type that has younger workers, no problem. All right. So whether, as the last bullet, whether a association plan implements or permitted distinctions and premiums is between its various employer members based on geographic location, worker classification, careful consideration should be given to ensure that these distinctions may not be deemed to be health factors. So you have to be, so the HIPAA rules apply to this one plan in general, so you've got to be real careful in designing your association. Next, can working owners without common law employees participate? And the answer is yes. If you're a self-employed individual and you have your own business and you have no employees currently under the rules under ACA, you cannot get group coverage. You cannot. You're stuck in the individual markets. Now they're opening this up and saying, okay, if you have you can join if you have an ownership right in a trade or business, earns wages or self-employment income from trade or business, and works at least 20 hours a week or 80 hours per month, and has wages or self-employment income from a trade or business. The problem is going to be in this situation verifying whether that person is actually, whether the association is assured that person is actually in business and not just from the general public. So there's going to be a form that they have to sign swearing the fact that they are a trade or business, and they're not just not, you know, they do have a valid trade or business. And that's going to be probably a very, now an association doesn't have to let these people in. But if they say, if the Chamber of Commerce says anybody's in the area can participate, and you say, hey, I have a small trade or business, I do X 30 hours a week, the association has to let you in, and they have to verify the fact that you're actually a true business. Now, what benefit rules apply to association plans? It's treated as one plan, and generally, there are exceptions, generally it's treated as one large plan. And here, if you're a small employer, one of the advantages here is that you don't have to provide essential health benefits. So again, all the rules that apply to large plans. So I'm helping one association in Texas do this, and they're getting quotes back from the insurance company indicating that the rates were 25% less. Now, I haven't verified that yet, and that's because, again, this plan, because it's considered a large plan, if you have enough people, do not have to offer essential health benefits. So now you have to meet all the other ACA rules. Are association plans subject to state rules regulating multiple employer plans? And the answer is yes. So basically, the plan has to file a 5500 and what's called an M1. And some states in the country don't allow self-insured MEWAs. So what's going to happen first is the first of these association plans that are going to be formed are going to be insured association plans. Now, like, for example, in the state of Illinois, self-insured MEWAs are not permitted. States like Colorado don't allow MEWAs. So you have to check with your state, and some states require you to register. So you have to file a 5500 federally and an M1 every year. But again, many states treat self-insured association plans as an insurance company. So like I said before, what's going to happen in this situation is that the first association plans are going to be insured. Here are the effective dates for fully insured plans are effective, in a few weeks, September 1st, 2018. For existing self-insured association plans complying with DOL rules, January 1st, 2019. And for self-insured association plans, it's April 1st of 2019. So you're looking at this and saying, okay, what are the pros and cons of these association plans? Well, again, here, first of all, there's an exception from various Affordable Care Act requirements. You don't have to offer essential health benefits. Now, you have to be very careful when you join an association plan like this, because you have to see what benefits they are covering. Make sure that it entails all the things that you want. Next, reduce reporting and disclosure requirements. Because we're dealing with one plan, there's going to be one 5500 and one SPD. So, and the association will provide that. So you don't have to worry about getting plan documents, and so it's going to be interesting to see if these association plans are going to be offering premium only plans, because there's some issues with those. So, and there's going to be economies of scale. Now, I just want to warn you that in the past, one of the problems with association plans have been the fact is that after a while, the healthy employees leave and the sick ones stay. And the premiums keep on going up and up and up and up. Adverse selection. So let's see if associations have learned their lesson from the past. But again, this is still early in the game. This is something that you got to be real careful with. The cons are, well, association plans are MIWA, so we want to see how the states are going to regulate this. And sponsors of association plans will need to exercise to ensure compliance with those standards, including those established under ACA. The drawback of being a MIWA is that under ERISA, states may regulate both insured or self-insured programs. And again, many states require even insured MIWAs to register. So you have to check each state that you're operating under to see what the rules are. And in some states, like Colorado, MIWAs are illegal. You can't have them. But if an association that's operating in one state, there may not be a problem. And if you're in a state that allows self-insured MIWAs, states are just an early stage of looking at this and seeing if they're going to allow it. But again, the experience of the 80s and 90s are coming back. And remember, is the fact that these association plans are subject to ERISA and other laws that apply to group health plans. So all the different federal mandates apply. There's fiduciary responsibility rules, both for the association and for the employer. Preventive transaction rules, ERISA disclosure, Form 5500, Form M1s, COBRA. If you join this plan, you're a small employer, you're going to be subject to COBRA. Mental health parity. Other ACA mandates are going to be subject. So again, since you're in a large plan, also you may have to offer family medical aid. Association plans must comply with HIPAA portability, privacy, and security rules. Small plans may become subject to mental health parity. Some people have raised the issue of maybe taxation of health coverage and benefits because the benefits are not being sponsored by the employer. I don't think that's the issue. And there also could be liability concerns. The preamble clarifies that compliance with applicable legal requirements, bona fide group and association plans, if the association plan fails to comply, it appears that in most cases, the liability of such failure will rest with the sponsor, but we don't know yet because it's still early in the game. And legal uncertainty. Given the association plans are new creation, they will inevitably face legal challenges. For example, there are 12 states have filed suit against these regulations as we speak, 12. So again, please be very careful. It's still early in the game. In the states I've talked to about this, they're indicating they're slow walking this, they're looking at this. They're analyzing exactly what the impact is. So there's a multitude of compliance obligations that attach to association plans. If you're thinking about this for you or your clients, be very careful. The MIWA status alone has significant state and federal implications. And you have to make sure whatever association you join, it's legally compliant and properly administered. It's going to have to be substantial. And that's why I think existing associations are going to be the first ones that jump into this. Before joining an association health plan, employers should consider all these issues. Okay?